Yeah, I don't know. Yeah. There it goes.
Well, ladies and gentlemen, a warm welcome from a beautiful Cape Town. As I look out the window, I see a cloudless sky, no wind, and a beautiful, majestic day with a beautiful view of the mountain. So it gives me great pleasure to welcome to episode 29, season 5, the last talk of this year. It's Dr. Zinn, and he's speaking about pelvic pain more than just a headache in the pelvis. You'll remember we started with Alan Alperstein, the A's, we're ending with the Z's, Philip Zinn, and we've had a lot of people in between. So it gives me great pleasure to thank Phil for being with us this afternoon, and to thank all the delegates, in fact, that have been with us so faithfully throughout the whole year. The sponsor this afternoon is the Pelvic Floor Foundation of South Africa. Phil Zinn is a person well known to many and needs very little introduction. He's a private practitioner from the Kingsbury Hospital, and he's an obstetrician and gynecologist with a special interest in endoscopy. Phil Zinn has been associated with all sorts of organizations over the years, and it gives me great pleasure to ask Phil to present on a particularly difficult topic, that's pelvic pain, more than just a headache in the pelvis. There can be nobody better than Phil for presenting on this particular topic. So Phil, without further me wasting your time, I'd like to say warm welcome to the Pelvic Floor Foundation, and we'd like to see your slides. If you wouldn't mind sharing your slides. While you're doing that, a special thank you then to Mr. N. Zaptier and Wendy for being our technical assistants throughout the whole year on this enterprise. So pelvic pain, not just a headache in the pelvis, more than just a headache in the pelvis. Dr. Philip Zinn.
Thank you, Pete. Thanks for that kind introduction. You did ask me to speak about this topic earlier in the year, and then surprised me by sending me a message to say we're looking forward to your vulvodynia presentation. But I managed to persuade you to take a step back. It's not an easy topic. There's a lot that one can say, and I'll try to limit myself to the time available, leaving time for some questions. But yes, pelvic pain is not just a headache in the pelvis, but often a headache to the practitioners who try very hard to help their patients. Pain itself, it's necessary to say a word about it, and it's often just instinctively known as an unpleasant sensory experience, which is associated with tissue damage. But it's not just that. It's more than that. It's an emotional experience, and we know that if somebody hurts themselves, they're not just going to pull away. They're going to respond typically with an F word, which of course might be fright or fear, certainly anger. But now it's not always real tissue damage. It may just be potential or anticipation of tissue damage, or it may resemble damage which is not real in physical terms. It's a highly personal experience, and it's influenced by biological, psychological, and social factors, as we know. And it's important to highlight the fact that nociception, which is the response, a sensory pain response to a noxious stimulus, it is not the same as pain. The signal gets to the brain, and the brain decides that that is pain. Life experience plays a huge role in the experience of pain, and memory of what those signals have meant in the past have been learned over time, and it's important to remember that this colors the experience and responses to pain. And therefore, we should respect this pain that somebody else describes as being real, whether the same situation in your own experience may not be regarded as painful as the person describes their experience is what counts, and we should take it seriously. Basically, if the brain concludes that the body is in danger, it reacts by letting you feel pain as it's put here in the allocated part of the body. So that allocated part of the body may not be the area that is typically experienced, that has actually experienced pain. I'm sorry, I've lost my presentation here. Pete, confirm that my presentation is still sharing.
Yes, Mosley and Butler, pain is a multiple output reaction.
Okay, no, I've just lost it on my screen, so I'm sorry about that. Okay, I've got it back, and now I've lost the.
We can see it in the corner there, Steve.
Yeah, we can still see it perfectly showing on our side, and we can see you and the presentation.
Can you not see your slides,
now.
Phil?
No, I can now. So the brain it's the best guess of what's going on that the brain is responding to. Perception is really an inference. It's a conclusion the brain has drawn, getting really a paucity of signals from the sensory organ that's perceiving it. Vision, for example, the picture you see, this rich picture, is made up of only about 10% of the sensory signals. And it's the memory that has been generated by those signals in the past that gives you the full experience of vision. And the same goes for pain. But sometimes the senses that are sending these rather rarefied, weak and Spartan signals are being interpreted in ways that are not necessarily real or appropriate. And these are known as sensor syndromes, where it's like the light on the dashboard of your car going off and the mechanic doing an assessment and saying there's really nothing wrong. The problem is the sensor. And this has been ascribed to conditions like chronic back pain, fibromyalgia, chronic pelvic pain, repetitive strain injury, and phantom limb pain, for example. And of course, the knee-jerk reaction is to send these patients off for psychotherapy. And while psychotherapy may be very important in the managing of these patients, it certainly shouldn't be your knee-jerk reaction to move them on to another discipline. And Atul Gawande has put this in a very nice article called The Itch, which you can just look up and read online. If you Google The Itch and Atul Gawande, it's a very interesting read that gives you some of this perspective. So once again, pain, the biological, psychological, social factors that are inputs to the experience of it is something we've all heard of before. But what about chronic pain? So this is a pain that lasts or recurs for more than 3 months. Recurring mean that, like severe dysmenorrhea might fall into this definition, for example. And it's 3 months, not 6 months. 6 months is the old version, but that was updated by the International Association for the Study of Pain in 2019. Typically, tissue damage and the pain from that acute experience resolves over about 3 months. And from the inflammatory to the reconstruction to the remodeling phase, it's about 3 months. So pain that continues beyond that has got another driver, which is independent of the original insult. And often chronic pain may have started off as a UTI and continue as bladder symptoms, but as the UTI is long gone. The same may be for something seemingly innocuous like severe thrush causing vulvodynia, or other conditions, surgical procedures that the healing of which seems pristine, but a pain sets off a sort of a pain condition which persists lifelong potentially. And this is to do with sensitization. Now, sensitization is basically something that's happening in the nervous system and the immune system, for that matter, which has a very important purpose in the acute situation. The sunburn, where the shirt where the shirt rubs on the sunburn and causes pain, that would be allodynia. It's not normally painful, but it is now, and that's appropriate. The reflex to pull your finger away from a hot stove makes a lot of sense. But if the sensitization in the acute phase doesn't resolve in the normal way over that 3-month period of time, and there are factors that lead to it persisting, then it becomes pathological. This happens peripherally, and the peripheral sensitization is to do with the actual area of receptors, where the specific spot that's usually painful now becomes a wider area. And it's influenced by this inflammatory soup of cytokines and mediators and growth factors, vasoactive chemokines, etc., which upregulate the performance of the receptors. It doesn't just upregulate the performance of them, but it actually causes them to increase in number as well. And then at the spinal cord level, there's an increase in activity and nerve endings and heightened sort of ion channels that are opened and multiplied. And then in the brain, there's a reorganization of the nervous system, at least the responses in various areas of the brain. In the peripheral area, it's what we call allodynia, when there is an innocuous stimulus, something that's not normally painful, which is now painful. And when something is painful, but is much more painful than it's expected to be, that is hyperalgesia. So, as I said, upregulation of the existing receptors, those nociceptors, there are now more of them. And all these inflammatory mediators which drive this response leads to these nerve endings triggering at a much lower threshold. And the increase in ion channels, increase the rate of signaling, the depolarization rate. New receptors are produced, they multiply, and they also become upregulated. And then the number of nerves actually increase. The mast cell degranulation releases a nerve growth factor, and that stimulates an increase in the number of nerves, which, when you do a biopsy on a dynia patient, for example, the skin that looks completely normal when stained with a neural stain can illustrate up to 10 times the normal number of nerves in a control subject. And the same thing goes for the endometriotic lesions in the peritoneum, richly innervated, where the surrounding peritoneum has a far lower number of nerve fibers. So the inflammatory mediators and the nerve growth factors cause not only just an increase in sensitivity, but also an actual increase in number of nerves carrying these signals. The prolongation of these noxious stimuli, let's just call them noxious stimuli, whether it's endometriotic lesions that are being activated every single month, whether it is constipation, whether it is bladder symptoms or recurrent UTIs, the prolongation of these cause an upregulation in the dorsal horn of the spinal cord, that central sensitization, and it leads to changes in the nerve, what they call neuroplasticity. The nerve connections change. There are increased connections, and the nerves start firing spontaneously, and that gives rise to what's known as neuropathic pain. The pain is no longer originating from the periphery, but it's actually originating in the dorsal nerve root, or in the nerve itself, as opposed to from its receptor. And then you get these collateral misbehaviors from organs in the area, where the problem with the endometriosis is triggering the bladder, and the bladder is triggering the bowel, it's triggering the pelvic floor muscles. So these then become new pain generators in their own right. And that IC stands for interstitial cystitis, which many of you would have heard of, now correctly called bladder pain syndrome. And then pelvic floor tension myalgia, irritable bowel syndrome, and vulvodynia as an example. And these are self-perpetuating. They get into a feedback loop, which just spirals and escalates quite easily. So there's an increase in excitability, there's a reduction in inhibition, the neuroinflammation, and the synaptic plasticity. I don't need to go into detail there. Another illustration of a diseased organ. Let me see if I can get my laser pointer here. Of signals coming from a diseased pelvic organ. Let's just call these endometriosis, peritoneal endometriosis implants, traveling up to the dorsal root ganglion, and then having a sort of a backward effect called an axon reflex in a nerve that's shared in this pathway higher up, going to the bladder, for example, or nerve afferents going into the actual dorsal root ganglion at the spinal cord, and then interacting with another nerve at this sort of point as a convergence point, and then going back to the bladder. And then you have signals going all the way to the brain via the diseased organ in the sort of blue route becoming the green route up to the brain, and the brain sending signals all the way back to the bladder. So at multiple levels, you have the sensitization system. And it's no surprise when you look at the hypergastric nerve and the pudendal and pelvic splanchnic nerves supplying multiple organs in the pelvis, that there is this confusion at the brain and central nervous system level. So this is why we get the coexistence, or what we call the comorbidities of a problem. Somebody complains of their irritable bowel, but then they also have, or are found to have, endometriosis, or vice versa. And they also have symptoms which turn out not to be recurrent UTIs, but actually bladder pain syndrome, or symptoms of a UTI where there isn't any infection. And the incidence is high of chronic pelvic pain patients. About half of them have endometriosis, and about a third of them have bladder pain syndrome. And many of them complain about their bowels as well. And you can see that this goes in all directions. Castellanos in his paper took a few different studies and put them together, similar things, and he came up with the evil quadruplet. So it's those we've already seen, the endo, the bladder pain syndrome, the IBS, but at the center he puts pelvic floor tension myalgia. And that's a very important one to remember. When you examine these patients, you'll see that they'll pull away before you even get to the point of the vaginal examination. When you do get to that point, everything's tight, and vaginismus is a problem, not just in the gynae examination, but potentially their primary problem with dyspareunia, for example. There's who can have a wee when your pelvic floor won't relax? As a physiotherapist say, it's the parasympathetic makes the muscles relax. It's the rest and digest, allowing enjoyable sex. So as opposed to the fight-flight reflex of the sympathetic nervous system, which gets those muscles tight. So it's the tight muscles due to pain, guarding the area, absolutely is a major target for management of these problems. So the mood disorders also intersect, and hugely important. It's a natural thing to be anxious about pain. It's a natural thing to have that when there's been an insult or a bad experience, you're going to want to avoid it. You're going to be jumpy if you've had been hijacked in the South African context, an example that people will understand. You're going to be jumpy every time you come to your driveway again or get into the similar situation. It's a normal response. So if something's painful, you're going to want to avoid it, and it's going to conjure up an anxious kind of reflex. And the anxiety itself triggers inflammatory responses, which can be measured. It's called the psychoneurohumoral effect, where psychological issues can lead to inflammatory changes measurable in increased mast cell concentrations in the bladder and such like. So why do some people get this? Why do some people get chronic pain and others don't? And as with everything, it comes down to genetics, potentially, where there's commonly a family history. The comorbidities of chronic pain syndromes, autoimmune diseases. When you're asking about chronic pain and patients tell you that their mother has rheumatoid arthritis and the other one has depression, and then there's possibly inflammatory bowel disease or something else, or severe migraines even. These are all things which coexist and cluster in these patients. And often anxiety will run in the family, for example. So there are genes called pain sensitivity genes, coding for ion channels. There are neurotransmitters genes in dealing with serotonin and dopamine levels. There are different levels genetically in terms of the inflammatory response, and polymorphisms to do with something called brain-derived nerve factor or something like that. And then the stress response, there are variants in the hypothalamus, pituitary, and adrenal axis genes, which code for the glucocorticoid receptor genes. So good genetic reasons why this might happen. And then we've all heard about epigenetics, where experiences either, well, we don't know necessarily about those that might happen while we're in utero, but certainly early childhood experiences, the chronic stress effects, repetitive pain stimuli can lead to alterations in chromatin structure, through DNA methylation, modification of histones, and microRNA expression, which are well-known mechanisms of epigenetic changes. So they are reversible, and this is important to know. Sort of DNA methylation, demethylation agents, anti-microRNA treatments, and valproic acid, for example, the anticonvulsant is known as a histone deacetylator, so deacetylation inhibitor. So there's a lot of work being done on the role of these things in managing chronic pain, but a lot of it is still early days. Nevertheless, we know the neuromodulatory drugs, the anticonvulsants and the antidepressants, play a big role in managing chronic pain. But this is where the functional medicine doctors, the integrative medicine, and just the good sense which comes from our advice to our patients of getting good exercise, having a healthy diet and quality sleep, and mindfulness-based stress reduction. All these things have been shown to modify the course of chronic pain conditions, and it's quite possibly through the epigenetic mechanisms. So we're not changing now. Let's try that. What do I do now? So you can go and read the pamphlet on initial management of chronic pain from the Royal College. It's available. You can read the American College one, and you can read the European Association of Urologists. There's no shortage of advice out there, but it can get pretty complicated, and it's difficult to find one's way around the patient, let alone the management. So one has to establish what the primary need is here. It's not necessarily focused on the pain, but rather the function or the effect it has on the ability to perform daily activities, such as a career. I have a patient who's an equestrian and teaches riding, and she doesn't want to stop doing that because of a pudendal nerve pain. So we have to treat it effectively. I have a pilot who's a similar problem, and has to stop flying because of not being able to sit for long periods of time, and getting spasms into the bladder and perirectally. People who have to travel, who have to sit still in the boardroom and listen, people who just do manual labor. But then there's the person who wants to be pregnant because the mother-in-law is on the case, and they have to sort of consummate the pregnancy. And it doesn't matter that intercourse is painful because they'll do other things. They just want to be pregnant. And you can see that while it might seem the right thing for us to sort out the sexual issues, we may be missing the point of what's going to improve the quality of life. Bladder.
There has been a question, yeah, sorry, just to interrupt, by Raylene Naidu, and amazing perspective, exclamation mark, talking about, can some of this be the cause of a neurogenic bladder diagnosed by a urologist in a patient with endometriosis? Or
yes, no, absolutely. I think the neurogenic bladder is also this another term for it's used as interstitial cystitis. It's another term used for bladder pain syndrome. But you actually the bladder expert, Steve. So outside of the chronic pain realm, I guess you get a neurogenic bladder for completely different reasons, like multiple sclerosis, for example.
Yeah. Now, we use the term neurogenic bladder more along the lines of someone who has a neurological cause for overactive bladder symptoms. And so while there is a lot of overlap between some of these symptoms, I think we would most likely not find a very clear specific neurological cause for the patient's bladder symptoms if there was, in these interstitial cystitis patients, painful bladder syndrome. So probably reserve the neurogenic bladder more for the patient who's got a neurological cause for bladder symptoms. And again, like you mentioned, MS, spinal cord injuries, even stroke, those kinds of things. But I mean, yeah, great question, and very relevant to the discussion. Thanks, Raylene.
So this anxiety might be a big issue, and some patients are just fearful of where this pain's coming from. What does it mean? Is it a cancer? Is there something sort of getting steadily worse that's going to completely incapacitate them? And catastrophic thinking is often a characteristic of chronic pain patients. And there are questionnaires you can use called the catastrophizing scale. And then there's the depression questionnaire. And all of these are sort of recommended and used in pain clinics, etc. But at the end of the day, you don't need to do a lot of questionnaires to actually come to a conclusion or build a picture of a patient in terms of what approach needs to be taken. What is useful about questionnaires may be to be able to highlight to the patient what their problem is, and they can see, gee, I'm scoring really high on this questionnaire, and that can be the start of cognitive behavioral therapy, where you're trying to change the narrative. And as you don't need to be the psychologist or psychiatrist, just as the gynecologist, you can already be rewriting the narrative or helping the patient to think differently. So it's important to identify what the triggers are, what's exacerbating the problem, and what's perpetuating it. And the periods and the menstrual cycle, this is a big thing. You don't need a period. You don't need a menstrual cycle unless you want to fall pregnant. And getting a period is just a penalty for not getting pregnant. It doesn't have a biological value. In fact, it's got a lot of biological negatives. But I'll come back to that. You don't need constipation. It needs to be dealt with, actively dealt with, because it's the cause of the pelvic floor tension myalgia as well. And then recurrent thrush is often not thrush. It may be, but if you don't do a swab and prove that it's resistant to fluconazole because it's Candida glabrata, you've got to find another reason why she keeps getting these symptoms. And that's quite commonly a mistaken diagnosis for what is really vulvodynia, which might have started as thrush, but is no longer. And the recurrent UTI are the same. It's no longer a UTI. Now it's a sensitized bladder and nervous system creating this bladder pain syndrome. And your approach is going to be different. So the periods of the menstrual cycle, well, endometriosis is commonly the cause of severe dysmenorrhea. And unfortunately, there's a lack of awareness there's more awareness now in the sort of modern social media using public, but at the same time, there's still these old-fashioned ideas that painful periods is a rite of passage for the young woman. It'll get better when you have your first period. You know, suck it up. We all went through it. This sort of thing. So it's a normalization of these symptoms. And the young woman who's missing school because of her periods, who's can't do her sport, who's on lots of medications, you've got to ask the question of whether this is normal or a pathology that is unfolding. But unfortunately, there's a significant delay from the symptoms to diagnosis. And if in terms of long-term management, you get rid of that pain, or indeed you solve her fertility problems due to her endometriosis, there is still this early experience, which is severely, shall we say, noxious and generating a memory which sets the scene for future chronic pain problems. So picking these things up early is really important. We know what it looks like. So if we talk about endometriosis as an example of sensitization, there's this soup of inflammatory mediators in the peritoneal fluid. It's up in this little picture here, coming from the peritoneal implants. So there's inflammation around the peritoneum spread far and wide by the peritoneal fluid. The lesion itself is a site of inflammation, and then the nerves, which, as I said, is very richly innervated, becomes sensitive. And this goes to the spinal cord, and then the central sensitization occurs there. So what about this pelvis? And 30% of our laparoscopies for severe pain are completely normal. At least that's how it appears. And we tell the patients this, and we think it's going to help them, but they're usually disappointed. They want a diagnosis. Alessandro Graziotti, professor in Italy, wonderful person who gives fantastic lectures on this topic. And if you go to a website, you'll get a wealth of information about pelvic pain and sexual pain, and etc. She wrote a paper saying that the pain may be the first sign. It's a symptom, but I'm saying it's the first sign of endometriosis. It's the first time player of a not yet visible disease. So when you don't see it, of course, it could be there at a chemical level. And if you biopsy the peritoneum of this patient that I showed you, you may well find signs of increased inflammatory activity and while the early signs of endometriosis. So you don't need periods. As I said, it's a burden that comes from family planning. There's up to 8 times the menstrual burden in women these days because of preventing pregnancy. You're supposed to have 12 to 14 babies biologically and be either pregnant or breastfeeding without periods. The only other mammals, most mammals don't menstruate. It's just the monkeys, the great apes, some bats, the spiny mouse, and the elephant shrew, and of course, yeah, that's right, man, and that's because of the type of placentas we have. Now, it's not just the period that's the problem, it's the cycle as well. And when the progesterone level plummets just before menstruation, it takes away a relative immunosuppressant state of being in the second half of the cycle. And it's like the horses being let out of the starting blocks at the races, where the inflammatory mediators suddenly surge. So the premenstrual fall of hormones is activating an inflammatory cascade, which leads to a period, amongst other things, but also the other symptoms of premenstrual syndrome. And many women who have autoimmune conditions, diseases, are more likely to get flare-ups around the time of their periods, just as they are postnatally. And of course, there are genetics that play a huge role in premenstrual syndrome. And you can see the patients who have anxiety issues may have far greater premenstrual dysphoria and are also at higher risk of postnatal depression. And then migraines are also part of the chronic pain syndrome cluster. So if we negate the periods and we negate the cycle, we're creating a sort of a calm that at least puts out some of the fires that are driving this chronic pain syndrome in the pelvis. I've mentioned constipation. The American Gastroenterological Association has a fantastic algorithm. You can look it up. It's free for IBS and for constipation, but let's say IBS-C, which is the constipation form, then IBS-D and IBS-M is the mixed, and they've got a great algorithm which tells you first line, second line, third line. But basically, polyethylene glycol, it's been shown to be the most effective, better than the fibers, fiber gel, for example. And this is where the physiotherapist we need the physiotherapist for a lot when it comes to pain management, that pelvic floor tension myalgia, but physiotherapists lead the way in pain management generally, not necessarily putting their hands on the patient, but they know how to manage the bigger picture of chronic pain. So physiotherapist involvement is really important if you can. But a pain specialist physiotherapist or a pelvic specialist physiotherapist, we're not talking about just trigger point muscle release. So the recurrent thrush I've mentioned, take a Q-tip and touch that vestibular area just at the base of the hymen. Sorry, you first take a swab and hopefully exclude candida. But the point is, when you look, you don't see vaginitis, you don't see erythema, you don't see white paint plaques of candida. And when you take this Q-tip and you touch at the entrance of the vagina, it's exquisitely sensitive. And that area has become highly sensitized, and that gives you a clue to vulvodynia. At the same time, you see the muscular responses. So you can give them some local anesthetic. And I keep a tube of Emla in the drawer where I can actually test it there and then in the patient that's complaining about provoked dyspareunia or dyspareunia, superficial dyspareunia. And some patients do extremely well. All they want to do is to be able to have intercourse with some comfort. And you give them this local anesthetic gel or cream rather from the pharmacy. It comes in a 30-gram tube. They can mix it with a little bit of moisturizing cream like Dove body lotion, and so that it's slightly more diluted. Smear it on that area, and 10 to 15 minutes later, that sensitivity is gone. And that puts out a fire, which allows you to turn the tide so that the next time they don't hold back. They're a little more relaxed. They know that it can be better, and they do. And a few months later, you find they're not even using it anymore. Maybe just a lubricant, but they now know they've got the confidence. Their body relaxes naturally. And then there's the amitriptyline and physiotherapy for that. And you can go and look up, you just Google vulvodynia algorithm, you'll come up with this. And it's a pretty good guide on how to approach it. So I mentioned the recurrent UTI. Yeah, we can sort out the real thing by giving nitrofurantoin for 3 months every day. You usually avoid the infections, and then what you're left with is the bladder pain syndrome, and this is a real thing. It's a loss of the glycosaminoglycans layer, protective layer within the bladder. And you can do a cystoscopy, and you fill the bladder up with about 400 mils of saline, or water rather, and as you let it out, you get this blood raining down as you decrease the pressure, and there may even be ulcers called Hunner's ulcers. So there are treatments for this, and there's again very good evidence for physiotherapy with myofascial trigger point release in terms of bladder pain syndrome. But there are also oral medications, and their bladder installations, and the main guy on the block is Cystastat at the moment, and it does work well. But I won't go into that now. Anxiety needs to be addressed head on. If you are, it can obviously be addressed.
Sorry, Phil, can I just mention
Go
the
ahead.
Cystastat, are you having good experience with the Cystastat? Because although it burst onto the market about 4 years ago for the IC patients, and for its cost, and it is a bit of a tricky thing to give, but I've really been a little bit disappointed in it, and I've reverted now to the more traditional installations. So it is interesting to hear your experience with it. But yeah, I've kind of stopped using it in a way. But yeah, I'd be interested to hear your opinion about it.
Yeah, look, there's a good review of bladder installations, which still puts it up there. There's another page besides this one, which shows some others as having the best results. But I find that, the last patient I used it in, it really did nothing. She had all the symptoms of bladder pain syndrome. But at the end of the day, she needed to spend a lot of time with a psychiatrist. She ended up being admitted for psychiatric issues. And so unless you're dealing with the other constellation of factors that play a role, sometimes it doesn't touch sides. So I guess it's there are going to be the pure BPS patients that'll do better. But yeah, I don't have a wealth of experience, Steve. And then there's the external stresses. So these things have to be addressed as well. And sometimes just a life coach can make a difference to helping them organize, reduce the stresses. But others have to change their career, get out of the fast lane, etc. And others have to sort out their family problems. These things are not small things. I won't say much about this. It's a real thing, and it may be to some extent cause, but it could also be result. And I'll tell you what, how many of your patients are walking around with chronic constipation? And we just accept it. They just accept it. It's a fact of life, constipation in women. And there are all sorts of reasons, but you need to address it if you're going to get rid of the pelvic pain. Not everybody with constipation has chronic pelvic pain, but when they do, you got to treat the constipation. And that may be indirectly by reducing the pain, reducing the pelvic floor muscle tension, or it may be directly by treating the constipation. So you take one of the triggers away. So try to keep it simple. Just get rid of everything that's bad. Like it's easy to say, but all the noxious stimuli, everything that's making it worse. Try to deal with it in an upfront way. Now, of course, intercourse might be making it worse. You don't want to get rid of that, but you might say, take a pause, just do outer course. Let's try and settle everything down. Let's get you on the trepoline for your vulvodynia, which, by the way, trepoline for vulvodynia, just as an aside, 75 milligrams is what you need, not 10 milligrams, and it works very well.
Sorry, Paul, I just mentioned something on the trepoline while you're talking about it. I think for the patients with the IC, it's I think it's something that I've kind of underestimated its value. And the more people you talk to, the more you realize that it's actually something that one should actually try and start quite early on in the treatment, the trepoline. So that's what I'm doing now. I don't know how you feel about it for the patients with a pure interstitial cystitis that you've actually diagnosed on cystoscopy.
Yeah, absolutely, Steve. It's got a big role to play, and the anticonvulsants as well. But trepoline is out there, well tried and tested, and it's got a good track record. And as long as you start it low and you build up slowly, patients do well with it. Give it early, sort of 6 o'clock in the evening, and they sleep better as well. So it's a great drug. It often the sedating side effects are less when you get to the higher doses, interestingly. But yes, I agree with you, Steve. It's been underestimated. So yeah, get your physiotherapist involved. There's a lot of interest in the physiotherapy community and pain management, and there's a lot of re-educated, shall I say, physiotherapists in that respect. And then it's difficult to get CBT. There are quite a few psychologists doing it, but you got to get onto a long waiting list. But you can. It's basically changing the narrative, getting this patient to
Sorry,
know.
Phil.
Yeah.
What is CBT?
Right. So that's cognitive behavioral therapy. So it's like,
what is it?
Yeah, so it's like rewriting the narrative. It's like changing the story. But now I'm not the expert on this either, by the way. But it's basically you're saying you're explaining everything to the patient. This is how the gynecologist does CBT. The patient must understand what it is. The patient must understand that they are in fact need to take charge of this problem and help to drive this finding the solution. It's not being done to them. They mustn't be the victim all along. So it's this sort of thing. It's changing the narrative. It's also saying, we don't have to get rid of your pain. We just have to reduce it to levels that you can function normally. And then this is how you manage it. This is how you approach it. This is the attitude you choose to take, etc., etc. So it's a psychological technique, I suppose, that is trying to use cognitive and behavioral methods to treat it. That's about as much as I can say. But it's not easy to come by. It's available, but psychologists are oversubscribed, unfortunately. So I've mentioned this, and I'm just saying this is what you can have as ingredients in your, let's just say, in your toolkit. I mentioned the EMLA. We've now mentioned the trepoline. Now, Lyrica is a good one. You've got to learn to use Lyrica. It's definitely a good pain medication. It's alongside the anticonvulsant gabapentin. Gabapentin's fantastic as well. It's just a bit more difficult in the dosing regimen and the doses that you have to choose. You can get effects from small doses and build up gradually. So I'm not going to say too much more other than, you've got to learn to use it and what its place is. When it comes to chronic pain, we talk about the antidepressant class and we talk about the anticonvulsant class, and they can have synergistic benefits. So you get side effects from all of these drugs, but if you use a sort of a half dose of the one and a half dose of the other, then you get synergistic effects which achieve your ends with less side effects. So there's a little bit of a trial and error, but the patient must buy into this whole program. And a lot of the problem is lost to follow-up of these patients. You see them once, you take a lot of trouble, and you don't see them again for a year, and they come back with the same problem. So you've got to get them on board, and you've got to work out a program, and you've got to explain to them that this is, process of how we're going to find the right recipe. The pill and the Mirena. Now, interestingly, drospirenone. So here we're talking, I'm going to use the brand names, Yaz, 20 micrograms of the estradiol and 30 milligrams of the drospirenone has been shown to be better in terms of chronic pain management than the other pills. And that's something I only recently learned. But any pill will help. Any pill will do. And skip the placebos, please. You don't need the downtime. It really just isn't necessary to get that period every month. If they start having breakthrough bleeding, you can take a break for 4 days. But skip the placebos. Don't drop the hormone levels. And then lastly, I think we're coming to the end. Keep what works and get rid of what doesn't. You should start to see benefits within weeks of starting. And remember, if there's an underlying condition, you've got to treat it. And you might do the surgery for the endometriosis, but if you can put it to sleep because you're not looking for fertility, then that's a good thing. And it's criminal to operate on endometriosis and not take measures to prevent it from coming back. Obviously, if you're looking for fertility, you're going to be proactive in that respect. But if you're not, you've got to put it to sleep so it doesn't come back. So identify those things that are causing flares, and patients keep pain diaries, for example, and intervene early so that when they taper off their medications and they start to get a flare, they know just to increase it again. And there are studies looking at prevention. And this is a sort of a topic for the future, but we're hoping to be able to identify at-risk patients in advance and prevent it from happening in the first place. Thank you for that.
Thank you very much indeed, Phil. Would you mind answering a few questions? We do have a few minutes, so there is time to indulge in a few questions. Would you mind, or?
No, no, absolute pleasure. Yes, please. I hope that's been helpful so far.
Yeah. Phil, one of the things that has been mentioned over here by our audience is that often there are preconceived ideas people do have, and it's very difficult to disabuse them. And you mentioned a few times the need for menstruation. And sadly, there are many, many women that do labor under the false impression that menstruation is important and menstruation is natural. And it's a very difficult thing to change conceptions and perceptions and trays in people's thinking. Excuse me. And this notion that menstruation is natural, I say, what is natural? They say menstruation. And I say that if you go out into the Kalahari and you look at natural women like the San and the Khoi, they don't actually menstruate because they have late menarche, they fall pregnant, they breastfeed for extraordinarily long periods of time, eventually re-ovulate, they fall pregnant, and the cycle carries on all the way to the menopause. And for that reason, you very seldom find sandfolk, if ever, that have endometriosis. And as you did clearly mention, endometriosis is an inflammatory condition, and it is attendant on this need to menstruate. So if you could persuade women that menstruation isn't necessarily useful, it's something that can help. On that tray, following that train of thought, would you say that the Mirena, again, which we're using trade names, the Mirena is useful for treating women with chronic pelvic pain attendant on menstruation?
Yes, absolutely. It's a wonderful tool. As you mentioned, on the period front, education is everything, and just to explain how the cultural sort of practices came into being, the renewal of fertility, the drop in hormones leading to a sort of a relief from the premenstrual tension, and the period was also the signal to the young men in the sort of hunter-gatherer phase that this woman was coming back into fertility. She became desirable, and etc. So, but yes, the Mirena is a fantastic tool because you are switching off the uterus and the inflammatory processes that go with menstruation, but also you are suppressing in the sort of a field effect, suppressing the endometriosis lesions in the surrounding area. So it's an anti-inflammatory, a fantastic tool, but it doesn't change the hormonal triggers that happen with the cycle. But it's a significant way in the right direction.
Would it be better, for example, to use a Mirena rather than knocking out the placebos in a low-dose pill? If you look at Zoli or one of those monophasic pills, not Clara perhaps, but Zoli and others, maybe Yasmin or Yaz, and knocking out the placebos, would that achieve the same effect?
Yes, it would. It's an individualizing thing, Pete. Often when one does an endometriosis surgery, you discuss in advance, you pop the Mirena in at the same time. For the person who has no particular problem other than severe dysmenorrhea and provoked vulvodynia and that sort of thing, negating the cycle is not necessarily necessary. But there will be those patients that get their cyclical migraines as well, or has their significant premenstrual symptoms and mood disorders, anxiety gets much worse. And those would be the ones that I would say, let's use the pill. And occasionally you've got a Mirena in, and then you say, oh, are we going to use the pill now as well for those PMS symptoms? So it's both have a role.
Okay, thank you, Phil. Steve?
Yeah, what about the role of you know, the constipation and the IBS type pictures? You know, a lot of the time we don't really think about, you know, getting you know, bowel people involved, and you know, where do you start with your investigations, colonoscopies, etc. You know, there's a lot of overlap in this area, and do you work with colorectal surgeons, etc.? Or yeah, it's a difficult one. Obviously, age dependent. Diverticulitis is also something that we always need to think about. Yeah.
Steve, absolutely. I actually omitted to have my trusty slide on the red flags, things that we mustn't miss in the initial assessment. So, you know, certainly one's got to look at other pathologies that might be playing a significant role here, and new onset constipation, things that just don't seem to make sense. But you know, there's a typical picture of the sort of chronic constipation from teenage years, the sort of element of hyper controlling element, the type A personality, the inability to sit on the public toilet comfortably, and the tension that you pick up when you do the vaginal examination, the irritable bladder, sort of that goes with it. So you build a picture of what's going on with the constipation, and you just, you know, my thrust in this sort of realm is to see it as just one of the comorbidities that goes with the pain. I suppose if you're dealing with a purely constipation problem and nothing else, then yes, you're going to be getting your gastroenterologist involved potentially. But I'm sure you've seen it as well, that, you know, the colonoscopy is done, it's normal, it's categorized as irritable bowel syndrome, and they're basically going to be doing what we could be doing ourselves.
Phil, thanks very much. We're almost out of time. If I may just ask one more question. You stress that, sorry, you stress that physiotherapy is an important adjunct in the management. Can you use any physiotherapist, or does this have to be a physiotherapist that's particularly adroit at diagnosing and treating this, and how would they treat it?
Yes, it's great to have the luxury of specialist physiotherapists, just like you have the luxury of specialist doctors. There are many places peripherally who don't have access to the specialist, and will have the physiotherapist that, you know, deals with back pain, etc. But now, fortunately, just as it is with the younger doctors, the physiotherapists are being educated extensively in the management of pain, not just as a muscle spasm, but as a sort of I hate the term holistic, but having the approach that's global, that looks at all the other drivers of pain. So, you know, at the pain congress, the physiotherapists are at least 50% of the contingent in terms of both attendees and lecturers. So they're very aware of it, and I think you can access any physiotherapist these days and ask them to help manage a pain problem.
Yeah, we've just had a whole lot of physiotherapists log on and say yes, yay for women's health physiotherapists. So there are lots of, and we do have lots of physiotherapists. When Steve and I have workshops, up to a quarter of the attendees are physiotherapists. They certainly are making a comeback.
Yeah, absolutely.
And Phil, you've got a son. Do you have a son that's a medical student?
He's a doctor now for a few years, Pete. Yeah.
Did they bring up this question of pelvic pain, or would they skirt around it? Is this something that's been magnified and concentrated?
Look, my son's interested in orthopedic surgery, so but my daughter has just finished bragging now, and she's told me a lot about the pelvic pain unit at Somerset Hospital, which is there's a lot of academic interest and realization. I think we're in a new age, and it's very welcome.
Yeah, no, I mean, I know about that Somerset pelvic pain clinic. It's run by Dion Kennedy. It's looking at mindfulness, some of the psychological stuff. So, yeah, a lot of good and deep interest in sort of the non-organic approach to this as well. So, but I mean, Phil, fantastic presentation. Thanks so much. It's, you know, you can't talk enough about this. It's, you know, these are difficult patients to treat, simply because they are suffering, and we often don't get on top of it. And, you know, we start to experience the same pain sometimes because they, you know, they come back to us and we're not really often achieving the progress. But I think, you know, for me, I think maybe learning to use the physiotherapists, use your colleagues, and spread the load a little bit is also quite good to do. So that's that was my 2 cents worth on that. But thanks. And I mean, just so we have come to the end of our
Episodes.
webinars for the year. Thanks to Phil for running it on a grand scale. I want to thank Pete for all his hard work. Pete spent a lot of time putting together the programs for these sessions with the team. But yeah, great. Thanks to Pete as well for all your hard work the last year.
Would you thank
But thanks
Pete?
so much, Pete. And yes, and of course, thanks to the team. I can leave that to you, Pete.
Wendy, I'd like to thank Nadir and Wendy. It's been wonderful having them. At the end of the year, we review all the successes and the failures, and we hope to build on the comments for next year. We're going to be starting in February. And remember that we're going to build up full to the FIGO meeting. I promised I wouldn't mention the FIGO meeting, and that's going to be in October. So I'd ask you all to diarize your FIGO meeting. It's the beginning of October, and we look forward to seeing you all there. So from all of us over here at the Pelvic Floor Foundation of South Africa, especially Steve, who's the founding doctor, director, and maestro, thank you all very much. And as I've said, Nadir and Wendy, but especially also to the people that log on.
Yes, thanks so much.
Log on religiously every single week. There's lots of people that are with us every single week, and to them, the support they give us is heartening. And of course, our industry assistants.
Yes.
So Steve,
thank you very much.
I look forward to seeing you here, same place, same time, next year in February, and we'll continue our presentations then. But Phil, thank you once again. It's been wonderful. The insights you've given us on pelvic pain, and thank you for your time.
Thank you very much.
That's
And
a great
have a good evening and have a good holiday, everybody. And we'll see you all next year. Thanks so much.